Hello viewers, I am Dr. Rabiul. I work as a lecturer of pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is hemophilia. In this video, first we will try to define hemophilia, then discuss its types, pathogenesis, and since hemophilia is a disorder of secondary hemostasis, so we will briefly discuss about hemostasis, followed by the clinical findings of hemophilia, laboratory diagnosis, treatment, complications, and prognosis of hemophilia. Okay, so let's begin. First question, what is hemophilia? The word hemophilia was derived from two ancient Greek words, haima, that means blood, and philia, that means affection or lust. So, the literal meaning of hemophilia is affection for blood or lusting for blood. But don't confuse this thing with vampire, okay? No, hemophilic patients are not vampire, they don't have lust for blood. As a matter of fact, this thing is a misnomer. The real meaning is different from the literal meaning. So, what is hemophilia then? Hemophilia can be defined as a common hereditary coagulation disorder due to deficiency or reduced activity of factor 8 or factor 9. Okay, so I am repeating the definition again. Hemophilia can be defined as a common hereditary coagulation disorder due to deficiency or reduced activity of clotting factor 8 or clotting factor 9. And one more thing you have to know, that this disorder is X-linked recessive disorder. Okay. So what do we mean by that? That means, like all other X-linked recessive disease, the males will be the sufferer of this disease and the females, the affected females, will be the carrier of this disease, and they usually will not show any symptom of hemophilia because they are having one healthy X chromosome and one X chromosome with the mutation. However, as we will see later, that there is a term known as symptomatic female carrier, and we will talk about that after a while. And sometimes female can also become homozygous, both X chromosomes mutated, and in that case females may also develop hemophilia. Okay, so the thing that you have to remember is hemophilia is an X-linked recessive disorder, and like all other X-linked recessive disease, the males are the sufferer and the females, the affected females, are the carrier of this disease. Okay. And to explain further about the X-linked recessive disease, you can see that I have drawn a simple flowchart here, and this will help you to understand the term X-linked recessive, because you need to know this. Okay, so suppose this is the mother. She has two X chromosome, and I have written one as XH because in that particular X chromosome, the gene responsible for either clotting factor 8 or clotting factor 9 is mutated. Okay, so that is written as XH. That is the mutated chromosome, and the other chromosome is healthy. This is the father. You can see he has one X chromosome and one Y chromosome, and you can see that these are the possible genotypes of their offspring. So you can see that they have chance of having a daughter like this, and in this particular female you can see that she has one mutated X chromosome and one healthy X chromosome. So, according to the definition of recessive disease, this will not show any symptom, because when we are talking about recessive disease, both genes must be mutated for the disease to occur. Okay, so these will be the carriers of hemophilia. But look at this offspring. This is a boy. You can see that he has one X chromosome, and unfortunately that X chromosome was the defective X chromosome that he got from his mother, and he has one Y chromosome. Now the thing is, since male have one X chromosome and one Y chromosome, if that only X chromosome is mutated, there is no second X chromosome to counter that mutation. Okay, so therefore even with one mutated X chromosome, the males become sufferer. Okay, so that was the explanation why X-linked recessive disease causes disease in the male, but the females are often seen as carrier. Okay, so now that we have defined hemophilia, now we will move on to the second part, and that was the types of hemophilia. So hemophilia can be of two types. They are named Hemophilia A and Hemophilia B. When there is deficiency of the clotting factor 8, we call that Hemophilia A. And one thing you have to remember, that Hemophilia A was discovered first. So Hemophilia A is also known as the classical hemophilia. And what about Hemophilia B? When there is deficiency of the clotting factor 9, which is also known as the Christmas factor, we call that Hemophilia B. And as this is occurring due to deficiency of Christmas factor or clotting factor 9, so Hemophilia B is also known as Christmas disease. Okay, so those were the two types of hemophilia, Hemophilia A and Hemophilia B. Now, which one is common? As a matter of fact, hemophilia is a very rare disease. Hemophilia A is, the incidence of Hemophilia A is 1 in 10,000 population, and Hemophilia B is even more rare. Say for example about 1 in 50,000 or 1 in 100,000 population. It's something like that. Okay, so Hemophilia A is the common one, and Hemophilia B is very rare. Okay, so now that we have discussed the definition and type of hemophilia, now we will talk about the pathogenesis of hemophilia. So, like I said earlier, hemophilia occurs due to deficiency of clotting factor 8 or clotting factor 9, and that deficiency is occurring due to some genetic lesion in the genes responsible for making these clotting factors, and those genes are located in the X chromosome. The types of genetic lesions will include deletion, nonsense mutation. You know the type of mutation where stop codons are produced, that is nonsense mutation. The genetic lesions may also include mutations that will cause error in mRNA splicing, and the severe cases of hemophilia will occur due to inversion. Recall that inversion is a type of chromosomal rearrangement where a segment of chromosome is reversed end to end. Okay, so that is the inversion, and that type of genetic lesion will result in severe hemophilia if that inversion involves those genes that were needed to make factor 8 and factor 9. And as a matter of fact, if there is inversion in those genes, then there will be complete absence of factor 8 or factor 9. Okay. And there is also another type of genetic lesion that can cause mild hemophilia, and that is point mutation. In those cases, the level of factor 8 or factor 9 will appear normal. However, those factors will have reduced functionality. Okay, and so that is briefly about the pathogenesis of hemophilia. Now, before moving on to the next topic, I would like to tell you three important informations, because you will be often asked these questions in the examination. The first question is, will hemophilic patients always give family history of hemophilia? Well, you must be thinking that hemophilia is a X-linked recessive disease. Here the males are the sufferer and the females are the carrier, so the patient may give history of similar symptoms in the male relatives of his maternal side of family. And you are right in most of the cases. However, in 30% cases, the patient will have no family history of hemophilia. Then how can you explain that thing? The thing is, in those 30% cases, hemophilia developed as a result of new mutation. Okay, and that's why there is no family history in those cases. But in most of the cases, the patient will give a family history of male relatives on his maternal side of the family suffering from similar disease. Okay, so that's the first point. The second important point that I would like to mention is about symptomatic female carrier. So I have already mentioned that in hemophilia, females are not the sufferer. They are just the carrier of this disease. Okay, but then how come sometimes the carriers themselves can develop mild hemophilia? Now recall that they are carrier. Okay, so their genotype is like this. One X chromosome has defect in the gene responsible for making factor 8 and factor 9, and the other factor 8 or factor 9, and the other X chromosome is normal. So this is a genotype of a carrier of hemophilia, and they should not have the disease, because since hemophilia is a recessive disease, both genes in both chromosomes must be mutated for the disease to express or the disease to occur. But then why are sometimes these carriers are becoming symptomatic, although mild but symptomatic? The answer lies in X chromosome inactivation. Well, I have discussed in details about X chromosome inactivation in my previous video, that was the molecular basis of cancer. But to say in short, during the blastocyst stage of development, in female, X chromosomes are randomly getting inactivated. Okay, and what's happening in these cases? The healthy X chromosome is getting inactivated in most of the cases, and as a result, so that is resulting in unfavorable X chromosome inactivation. There is also a term for that, that is unfavorable lyonization, and that is resulting in symptomatic female carrier of hemophilia. Okay, so keep this word in your mind: symptomatic female carrier of hemophilia. They are carriers of hemophilia, they have genotype like this, and still they are showing mild hemophilia. Why? That is due to unfavorable X chromosome inactivation or unfavorable lyonization, and in that the healthy X chromosome is getting inactivated in most of the cases. Okay, the third important point that you have to know is, can female develop hemophilia? Yes, females can develop hemophilia, but to develop hemophilia in female, there has to be homozygous mutation. That means their genotype has to be something like this. Both X chromosome, one came from the mother and one came from the father, both must be mutated. And this commonly occurs when there is consanguinity, that is marriage between family members of the same affected hemophilic family. Say for example, if the father had hemophilia and the mother was a carrier of hemophilia, then they will have a daughter, whose genotype will be something like this, and that daughter will develop hemophilia. So now we will move on to the next point, and that was regarding hemostasis. Now this is important. In order to understand hemophilia, we have to have some knowledge about hemostasis, because those clotting factor 8, clotting factor 9, those were needed in secondary hemostasis. Spontaneous arrest of bleeding. Okay, and there are several steps that occur in order to stop our bleeding. And as you can see, I have drawn a simplified flowchart here. So first there is a trauma, and that will result in some disruption in the endothelium of the blood vessel, and then blood will leak out, and that is bleeding, right? And then what will happen? Well, initially there will be some vasoconstriction, and blood vessels in those affected area will become constricted. Okay, and then what will happen? Then there will be formation of platelet plug. And in order to understand the formation of platelet plug, you can see that I have drawn another image here. So in this image, this is the blood vessels lumen. These are the endothelium. This is the nucleus of the endothelium, and beneath the endothelium that I have drawn here in red, this is the subendothelial collagen. This is also the subendothelial collagen, and I hope you can see these dots that I have drawn in the subendothelial collagen. Those are known as von Willebrand's factor. Okay, so this part of the blood vessel has been damaged. As you can see, the endothelium has been disrupted, and the von Willebrand factors that were on the subendothelial collagen are now exposed. Then what will happen? They will attract platelets. You see, these I have drawn are platelet, and they will come and they will attach with these von Willebrand factors in the subendothelial collagen, and they will attach by using the GP1B, that is a glycoprotein, GP1B glycoprotein on the surface of the platelet, and this is known as platelet adhesion. Okay, so always remember, a lot of my students get confused with the words platelet adhesion, platelet aggregation. So platelet adhesion occurs first. Then what will happen? Once the platelets are adhering with the von Willebrand factor, and von Willebrand factor is in fact acting like a bridge between the subendothelial collagen and the platelet. So once the platelets through their GP1B have bound with von Willebrand factors in the subendothelial collagen, the platelets will get activated. Okay, and the activated platelets will develop pseudopod. As you can see, I have drawn the activated platelets here in a larger scale. Okay, so these I have drawn here in a zoomed out manner. So look at these things. They have developed pseudopods, and they will form aggregation. Okay, so more platelets will come and they will aggregate, and they will use, what is this thing? This is fibrinogen or fibrinogen. So they will use these fibrinogens to act as cross link between these platelets, and this is known as platelet aggregation. Okay, so to say even in more details, during platelet aggregation, the platelets will express GP2B3A glycoprotein on their surface, that is GP2B3A, and those glycoproteins will cross-link with fibrinogen. Okay, so they will use fibrinogen to cross-link between more and more platelets, and that is how the platelet plugs are produced. Okay, so that was the second thing happening in the platelet. So first there was platelet adhesion, and then there will be platelet aggregation, and they will form a platelet plug. But the problem is this plug is unstable, and in order to stabilize that platelet plug, there lies the role of the clotting factors. Okay, so that is the role of secondary hemostasis, to make the unstable platelet plug stable, and they do that by making fibrin. Okay, so as you can see, I have also drawn that here. So the coagulation pathway will ultimately make fibrin, and that will stabilize the platelet plugs. Now the last thing that I would like to mention regarding hemostasis is about the coagulation cascade, because they are important for secondary hemostasis. So in the coagulation cascade we have two pathways. One is the intrinsic pathway and the other one is the extrinsic pathway, and then there is the common coagulation pathway, and we have different clotting factors in different pathways. And you can have a lot of ways to remember this difficult pathway, but the way I remember is I begin with 10 and I just think 5 multiplied by 2 is 10, and also 5 plus 2 is 7. So if I can know 10, 5, 2, 7, then I just put the rest of the clotting factors on the other side, and then I get these pathways. Okay, so you can try that. Begin with 10, then think 5 times 2 is 10, 5 plus 2 is 7, so you put 5 here, 2 here, 7 there, and put rest of the clotting factors on the other side. And this is the intrinsic pathway, so the clotting factors 12, 11, 9, 8, all are needed for the intrinsic pathway of the coagulation cascade. Similarly, clotting factor 7 is needed for extrinsic pathway. And the reason I'm telling you this thing is we can get an idea about the defect, whether that defect is in the intrinsic pathway or in the extrinsic pathway, by measuring PTT and PT in the blood. Recall that PT means prothrombin time, and prothrombin time gets elevated when there is some problem in the extrinsic pathway, and PTT means partial thromboplastin time, and partial thromboplastin time will get elevated if there is any problem in the intrinsic pathway. Okay, and you can see that factor 8, factor 9, they fall in the intrinsic pathway. So in case of hemophilia, as there is reduction in factor 8 and factor 9, so the partial thromboplastin time will get elevated and the prothrombin time will remain normal. Okay, so that is an important point that you have to remember. So now we will move on to the next topic, and that was the clinical features of hemophilia. So what are the clinical features of hemophilia? Patients with hemophilia can have bleeding for hours or even days after injury. Joint bleeding, which is also known as hemarthrosis, is a very common symptom in severe hemophilic patient. The commonest joints involved is the knee joint, followed by elbow, ankle joint, shoulder joint, hip joint, wrist, etc. Okay, so joint bleeding is very important clinical finding in hemophilic patient. If the patient is a baby, since babies have very sharp teeth and they tend to bite their gum and tongue, so there may be bleeding from those sites for a long time, and also there may be bleeding for a long time after tooth extraction. Another important clinical finding is bleeding from soft tissue and muscle. Say for example the iliopsoas muscle, which is found around the hip, there may be bleeding from that as well. And intracranial hemorrhage, oropharyngeal hemorrhage, these two are very rare symptoms of hemophilia, but when present they can be very dangerous. Now, one thing you have to remember, that the clinical severity of hemophilia correlates with the level of deficiency of the clotting factor. Say for example, in case of hemophilia A, if the level of clotting factor 8 is below 1% of that of the normal level, then there will be severe hemophilia. If the level of factor 8 is between 2% to 5% of that of the normal level of factor 8, then there will be moderate hemophilia. And if the level is between 6% to 50% of the normal level of the factor 8, then that will result in mild form of hemophilia. So always keep that in your mind too. So now we will move on and discuss the laboratory diagnosis of hemophilia. So what are the laboratory findings that we will get in a patient of hemophilia? So the blood coagulation time will be prolonged in severe cases only. Prothrombin time will be normal, because recall that prothrombin time increases when there is defect in extrinsic pathway, but factor 8, factor 9, they are located in the intrinsic pathway. So prothrombin time will be normal. However, APTT, that is activated partial thromboplastin time, will get elevated, and then we have to do some special tests, say for example factor 8 assay or factor 9 assay, to further identify the hemophilia as hemophilia A or hemophilia B, because we need to identify the deficient factor in order to treat hemophilia properly. So now that we have discussed the laboratory diagnosis of hemophilia briefly, now we will move on and discuss the treatment of hemophilia. If the patient has mild hemophilia, then we can treat that with desmopressin acetate. This drug increases the release of factor 8 from its storage site. However, if the patient has severe hemophilia, then we have to infuse recombinant factor 8 to treat the patient. Okay, so that is in short about the treatment of hemophilia. And now we will move on to the next point, and that is what are the complications of an untreated case of hemophilia. Now remember, if hemophilia is not treated, then it can cause a lot of problems. Say for example in the joint, the bleeding in the joint will result in joint damage. There will be pain in the joint as well. Okay, and there will be damage to the muscle. Sometimes there may be rarely a thing known as compartment syndrome. In compartment syndrome, there is bleeding inside the muscle, and that gives pressure on the arteries and nerves inside the muscle, and that may result in damage in the limbs. Okay, there may be severe anemia and blood loss, and there may be bleeding in the gastrointestinal tract, and sometimes there is bleeding in the urinary tract that will result in hematuria. Sometimes the blood can get clotted inside the urethra, and in that case urine outflow may become obstructed, and sometimes the patient may have a sharp pain in his lower abdomen. So these are the complications of hemophilia. Sometimes in extremely rare cases there may be intracranial hemorrhage or bleeding from the oropharyngeal cavity, and those can be really dangerous. So we are almost at the end of today's video regarding the prognosis of hemophilia. If proper treatment is given and proper diagnosis is made, the prognosis of hemophilia is good in most of the cases. Most of the patients of hemophilia can lead a normal life with the modern treatment available now. Problem arises when treatment was not given properly or the disease was not diagnosed properly. In those cases, the complications that I had mentioned a while ago can occur. And also sometimes there may be a complication due to formation of inhibitors. Inhibitors are produced against the recombinant factor 8 or factor 9 that we use in the treatment of hemophilia, and those inhibitors are sometimes formed as a result of our body's immune response, that is thinking those recombinant factor 8 or factor 9 as foreign substance. In those cases, treatment can become difficult. So this concludes today's video on hemophilia. For my students, I hope you will go through your textbooks to know much more information about this topic. And for my viewers, thank you for watching this video for such a long time. I hope this video was helpful. I will try to upload a new video on von Willebrand's disease, hopefully within a week. Until then, take care and stay blessed. And also, if you like my videos, do subscribe and comment in the comment sections below and let me know. So take care and thank you.